one whole year onwards, I know your your focus is going to be more and more razor sharp because you would be actually groomed in regional anesthesia. And I'm quite also sure that once you pass out of this 1 year, you're hardly going to do a case without a regional block unless and until you have a good enough reason not to do so. I am going to take you today in the world of fascinating world of pediatric regional anesthesia. We have spoken about caudals and we have spoken about epidurals to no end. And now today I'm going to open up peripheral nerve blocks in pediatrics to you. And we are also going to look at catheter placements, as it were, and what are the issues with continuous catheters. As we do in adults, this is very much possible in pediatric population, and we shall see how. Oh, well, if we there is one disclaimer or caveat, or would you call it a warning? Yes, nobody should keep catheters in anybody unless we have a team dedicated to go there and look after it. If we don't have, then it becomes nobody's job. And nobody's job is a very sorry situation. So if not you, at least your entire team, your co-consultants or your juniors or your students, whosoever, should be able to follow up the catheters. So that's what is the first prerequisite for learning this. Now we should come to certain reasons as to why are we sitting here at 7 p.m. in the evening after finishing the work of the day and focusing on this particular subject. So let's go into the details of it. Why peripheral nerve blocks in children? What is the scope? Let us visit them via case scenarios, the drug dosages and infusions, and what is latest in this. What has changed in a couple of years, say in 2023s and 2024s. The parental involvement, how much do you need? It's totally different here. The parents are going to be watching you out, by the way, what we keep, how to monitor it. They would want to be involved in their child's care. And if the child is grown up enough, they themselves are very smart and astute to give you all the feedback. So let's see how we can involve and support them. Problems inherent to catheter placement and transition from catheters to oral analgesics. That's something that is so overlooked that it almost undermines the total efforts of that pain-free 48 hours. Not pain-free, but comfortably pain-free 48 hours. I know we sometimes do get absent-minded. I know sometimes we do get overwhelmed with what's happening around us. Could you please keep all your speakers off so that I don't hear all the secrets that you are speaking? Let's go that way now. So why PNB in children? Short surgery, single shot plus additive should be good. They go home the next day. I know, so many cases are like that. Prolonged and invasive surgeries with lot of post-operative pain? Yes, that is the dictum. That is the way to go for peripheral nerve blocks. Why can't we give central neuroaxis blocks? Suppose if it's an upper extremity case, obviously then you go to the upper extremity continuous nerve block. Lower extremity, we could still catch up with sciatic or femoral. Let's hear the story of it a little later. However, let me tell you that dictum of modern pediatric regional anesthesia is to go as peripheral as we can. Having said that, each case is different and each case has to be understood in its own way. Let me tell you the impact of this. Well, if this is how you have a child in the post-operative period, and in fact even refuses to have a feed. Let me tell you that if they're angry and they're in pain, they forget to do that. Give a top-up boluses. This was way back in 2006 where we did not have Baxter pumps, or in other words, elastomeric pumps to put to these children. We used to have syringe pumps, and sometimes I used to get so worried putting syringe pumps so that they could be gone to the IVs instead of the epidurals. I would go and give, and I would train all the sisters around to give top-ups, and they used to I they used to very conclusively tell me the effect of a top-up. Another story in the post-operative pain relief is, look at this child here. Okay, this is actually a single shot block with a additive. 4 hours post-operative, and I'm trying to understand why was he crying so much. I give him some milk to suckle through his mom, and there is unilateral foot correction with sciatic and clonidine in it. This is how it goes on. I try to bother the lymph which is operated, and he suckles away to glory. And then I bother the lymph which is not operated, and here you go. So this is how regional anesthesia actually works, but it's important to understand the child overall, because pain is just one of the situations where, or one of the reason why the child may be under discomfort or might visibly appear as as a very uncomfortable child. But let me tell you, they all are a bit of drama kings. Well, so the scope here is we can manage intense perioperative pain. We can have a therapeutic approach to ischemia. In fact, we can have therapeutic approach even in cath labs. We'll come to that if time permits, and of course in chronic pain. So there is definitely a role, and here is how we are going to look at it. Suppose if he is a 1-year-old posted for CTV correction duration 3 hours, but CTV is an extensive procedure. However, you could go it with a caudal block plus clonidine, sciatic plus femoral block. Sciatic becomes a primary block, put clonidine in the sciatic, or then give a sciatic catheter. You have three approaches towards it. So if that is your work today, maybe you can put a sciatic continuous. We can actually put the sciatic under the ultrasound, and then we can actually go with an epidural needle. This was again done way back, and here the probe is prepared by Bacillol, which was a solution very well told to us that it is recommended to clean and disinfect probes and use it. So, and once the tip of the needle is kept next to the sciatic nerve, we could thread the catheter. So in other words, what I can tell you is, if you see a nerve and if you see an area around it, you can put a catheter, provided we have good indications and provided the anatomy of the surrounding area is actually rendering itself quite well to it. First, second, it does not come in the field of the surgeon itself. So this is how it would actually appear. This is a Tuhi needle, and that's the catheter coming out from here. I would really appreciate. I mean, I know I have asked you all to off the mics, but if somebody wants to stop me at any point, they can please open their mics and speak to me, ask a question. If I just want to tell you that take this as a very informal, interactive class. There is no big officialness about this. So I would highly appreciate if you ask me. So you know what is the fundamentals behind putting a peripheral nerve catheter? Suppose if this is a sciatic and my Tuhi needle has approached here. What have I done is, suppose if this is a 20-kilogram child, I want to give 0.5 ml per kilogram of the bolus dose. So what would I do is, I would 0.5 ml per kilogram. So for a 20-kilogram child, I have 10 ml in my syringe of 0.25% bupivacaine or 0.2% ropivacaine. Now what would I do is, I would identify the sciatic nerve and I would give, say, half the dose around it. Now what would happen? This dose is going to serve two purposes. Number one, The nerve starts bathing and the block starts picking up. Number two, this anicogenicity is a background on which you see the catheter jetting out of our needle very well. So this is how it would be jetting out, and this is the Tuhi needle which has ended here, and this much is the catheter. So this principle can be applied anywhere you want. It can be applied in fascia iliaca compartment. It can be applied in infraclavicular. It can be applied wherever you wish. So this is how we would go. But suppose if you have a case where you cannot identify the sciatic nerve very well. These are muscles which are actually very fibrous and you can't really identify. And maybe if the ankle joint is a bit fixed and you can't really get the nerve stimulation response by going to each of them and you really don't know which is the nerve, unlike a normal musculature, a normal MSK, and you see a good sciatic nerve, then this is not the case to go for a peripheral nerve block. I would urge you to go to the central neuroaxis and give a block there. Put in a catheter if the case deserves, if the patient, if the surgery is that pain intensive. So keep all your choices open is what I would still would say. Now, is there any other modality of putting a catheter? I'm going to share that with you. At the same time, I'm going to tell you the pros and the cons of it. So, this is how it would go. This is a nerve stimulating catheter. Having said that, it was pretty much fun to do this work. At the same time, there it had its issues. So, well, this was a nerve stimulating guided block given at the mid thigh. What is the puncture point? What is the trajectory? And what is the end motor response? These are the three things that one needs to know. So what we can do is either convert it into a dual modality. So the puncture point is decided by ultrasound. If we do not want to do a dual modality being Puritans, then if we are, then what we can do is, let me get back to the video here. I'm going to get you back to the thigh in lateral position and I'm going to describe yeah. Suppose if you were to have a pen right now, it is very much similar to adults, in fact. The only thing is the ischial tuberosity and the greater trochanter would be actually felt very well in lateral position to so keep them laterally and then draw the point at the apex of the popliteal fossa and join the whole line, and that's the path of the sciatic nerve. And you can then distribute wherever and go ahead with the nerve stimulating needle with a current of say maybe 1 to 1.5 and go ahead with all the rules of the PNS. No muscle relaxant, of course, because this is a concomitant general anesthesia, and go ahead with this approach of putting in a sciatic nerve catheter. Now the cons, the pros you saw, it's like the end motor response stares at you. The cons, it's an expensive catheter. The same thing can be done extremely well and with good efficacy if at all we are using an ultrasound. So ultrasound, which is always going to be there, and then a simple epidural set works for us. The only problem is tunneling. That holds true in both, so we will come to it a little later. With this kind of a needle, we can still tunnel. We'll come to that a little later. Now, he's a small little one and he has a humoral discontinuity. And we are going to, it's an extensive procedure, let me tell you, with bone grafts and all the other things that come along with it. Actually the bone is being eaten away by tuberculosis. So we can keep catheters here, not that we can't, but then the neck is so mobile, they're going to come out in no time. So actually after putting that, this was my first and last interscalene catheter in a child. I realized that there is no point because they get avulsed. In those days we used to have a nerve, I mean we would not I don't know how to put it to you. I did not have ultrasound then. I know I'm just sharing the stories with you. So I used to create this out of an 18 gauge cannula and remove the blocker, the white blocker, and get the alligator to touch the metal of this cannula. Get inside with it, with nerve, with the landmark guidance block, PNS, get the stimulation, go ahead, remove the stillet, and then putting the catheter. So, but this was my first and last interscaling. I told myself that I'm not going to do it anymore. Interscaling, well, this was the case previous. It's an apt epidural catheter, a grown-up kid, worth doing if the case is worth. The only thing is when you have to be very vigilant because there are important structures around to get unnecessarily blocked. One is of course the phrenic nerve, other bigger arteries and veins are all around it. So you can see the epidural needle here, and you can see the catheter, and we all can easily guess how much catheter to keep in. It depends upon the area. If it is a neck, then nothing more than 2 to 3 centimeters from the tip that we can actually get into. In older children, again, if the case benefits, we should go ahead. In smaller children, I've given up. So this is a radial club hand. This is the place where we have kept maximum catheters till now. So 6 years old, posted for radial club hand repair. Very interesting. You can see that she's operated for a cardiac anomaly before. Or say a baby in an NICU but now gets an ischemic hand due to extravasation. So here a real good case to keep a continuous catheter in the intraclavicular area. Let's come to more details of this. Now, if this was a scan, we all know that this is pec major, pec minor, this is the axillary artery, and these are the lateral cord, the medial cord, the posterior cord, the illusion of the posterior cord, as it were, because this could be a hyperechogenicity immediately posterior to a very sonolucent structure. So it can be missed as a, or rather, it can be misidentified as a posterior cord. However, the blessing here is posterior cord indeed always, most of the times, is very central and very posterior to the artery. So we get our needle here, create a hydrodissection with the local itself so that it works, and we create a space as well. So this is how the catheter can be kept. There's another example that I can show you where we could actually get a good amount of sensories and motor separation. We'll come to that a little later. So, I always used to feel that in adults, the whole literature gives such importance to the posterior cord. You come to the posterior cord, you inject, you form the double bubble sign, and one will never miss that block. It does not happen in small children because the fascias are softer. Even the coverings around the nerves, I presume, are softer. They do not have those tough connective tissues. So they're suppler. LAs can percolate better. Their planes are demarcated, but demarcated again with softer tissues. Hence, there is no hard and fast rule for us to really seek the posterior cord in a baby or an infant where the pleura is going to be so close. We wanted to prove it. So what I did was put some dye when when the needle was right next to the lateral cord, and put the dye when the needle was next to the posterior cord. It gave me the same spread. Having said and done this, I'll tell you one more thing. The world literature somehow is speaking that the dyes walk from this area almost till the neck. Maybe it happens in the costoclavicular because we are very close to the clavicle. But from here, out of all the cases that was done, neither in a single one I saw the dye going up in the neck. So from the infraclavicular region, it is my experiential truth that the dye does not go above the clavicle. Coming to lumbar plexus blocks. Lumbar plex, like, have you realized that we have chosen those blocks to put catheters around where the anatomy is flat, such as sciatic, flat anatomy, infraclavicular, flat anatomy, renders itself extremely well for catheter fixations. This is also a flatter anatomy. So we can go ahead with a single shot needle if you want to try and understand the path of the needle. Go with the dual modality because the block is worth a dual modality. And once we get the quadriceps contractions, then of course we know the path of walking to with a epidural catheter. So that's how a lumbar plexus block in a child can be given. We need to be patient. It will be seen well. And you can see the contractions here. So what we could do is, I'm not sure whether the video is complete with the catheter. We can dive space and the ultrasound is going to show you the anechogenicity of the drug. Now we could go with the 2E needle and put the catheter in there. Another way of doing it is via the QL, where you see the lumbar plexus jetting out. That is where we can keep the catheters. And yes, by the way, let me also tell you this, that facial plane catheters is also possible in children. It's not just peripheral nerve blocks. However, managing two catheters is extremely difficult in a baby or even small children for that matter, because you'll have to calculate so many dosages. So I rather go to the central neuroaxis. Now, let me share another case with you. Let's come back to the foot. Suppose if we have a bilateral foot here, both the feet are going to get operated and the spine is bad. The spine is operated, suppose. So what then we do? It's a case of scoliosis and hip dislocation. Another case, not bilateral but hip dislocation, and you want a profound analgesia in the postoperative period. It's a central core disease and the risk of malignant hypothermia is really over your head. So you would want to discard the machine. You probably want to get the PICU ventilator, or you want to simply do that case on DIVA plus LMA on oxygen via an oxygen cylinder. So if this is what we wish to do, then our blocks need to be extremely precise. And then somehow I feel that if I want that precision, I would use an ultrasound fine. I would get an intervertebral space fine. But when the catheter really walks in there and my ultrasound windows are not going to be as clear as I want them to be because these are grown-up kids, I would put in a dye and see whether I'm really going to get those kind of spread, which is exactly an epidural spread. So once I do this, then I will go ahead and do the case. So this is how it would be done, and that's the role of continuous ones. Coming to again a good central neuroaxis block, a caudal epidural, you might just not have a sacrum. The patient does not have a sacrum. This is sacral agenesis. And this particular child comes for a bilateral uretary reimplant. There is no peripheral nerve block to go to. Come to a central neuroaxis block and come a little higher up. We need sacral levels, remember. So get the bevel which is pointing towards the sacral end so that you get the sacral innervations for sure. But if while passing the catheter, if we get an issue, if we have resistance, we are not going to do that job. Then we will think probably what else can be done, probably go multimodal, probably go towards opioids in that case. So that's the utility of regional anesthesia continuous blocks in such cases. Suppose again now we have central neuroaxis with this kind of a deformity. It's a deformity of the spine bifid. It was operated a while ago when the child was small. Now the child comes to you again. for bilateral foot repair or a hip repair, then what do? We could go, not that it's not impossible, but have an MRI before you put in, or at least have an ultrasound scan done and pick up that interspinous space, intervertebral space, which has a good bony osseous framework. However, take consents, discuss with your surgical team, discuss with your patients, that is, they have to be in your team to understand this. And if they don't opt for it, don't go for it. Coming to certain issues and certain controversies regarding this. The controversy is, can anybody guess what the controversy is? Anybody? What would be an issue to keep an upper extremity catheter in a radius or an ulnar work or both bones? I'm
Is it related
waiting.
to compartment?
Sorry?
Is it related to compartment syndrome?
Yes, of course, yes. It's compartment syndrome. That is something that we would always be very scared of. Could I know who spoke?
Yes, sir, ma'am.
Yeah, because you sounded as if you're off AORA, but I still knew it was you.
No,
Are you
I am
driving or something?
driving car and
Yes, it's like that.
through Bluetooth.
Yeah. Oh, wonderful. Okay. So now what do you do with it? The pain would be intense. And in fact, you can be an aid to your surgeon to diagnose a compartment syndrome if you've mastered this. Give a single shot block. Make it say 0.2% ropivacaine. I'm telling you my concoction. Keep lignocaine adrenaline aside because it might give you a motor block. Keep an epidural catheter inside the brachial plexus with ultrasound, maybe lateral to the lateral cord. And tunnel it and keep it. This is the tunneling shown here. Now what do? Is do not activate the infusion unless you have seen the motor function. Stop there. This typically takes 3 to 4 hours of correction. And once we demonstrate this, a good motor movement, he's just able to move his fingers. Anyway, his fingers weren't moving much, but this was his possibility. And there are slabs, if you can see, that they're not totally plastered. There's a slab. And then have ropivacaine, the infusion started. And now if the pain is comfortable, the child is comfortable talking to you, eating some nice sweets, you can see the sweet box also. Continue the paracetamol, continue this. After a few hours, if you get a call that the child is now in pain, and all that you have to see is your infusion is not hindered, the catheter is not kinked, the infusion is still going ahead. But still, if the pain is intact, we should not be escalating analgesia. That is the time to call the surgical colleagues. They will be able to pick up compartment syndromes due to you if we do this. Don't give them a dead extremity. That is the reason for compartment syndrome. Not a pain, sufficiently managed pain is never an issue with compartment syndrome. It doesn't do that. The same story in the sciatic also. However, I can share my observations with you. With sciatic block, the motor blockade lingers a little longer. I'm not too sure why. The biggest nerve in the body actually gets numbed very quickly under ultrasound. And if we use very dense local anesthetics such as 0.5 or 0.25% bupivacaine, it carries on for a very long time because we are very, very close to the nerve in children. So we choose to go towards levobupivacaine, a little lower concentration, maybe double diluted, or ropivacaine 0.2 is a good dilution. Or if a surgery is a long one, then we don't mind 0.25% levobupivacaine or bupivacaine even. However, we refrain from activating our infusions unless we have really seen the motor block residing. Only then we start. So the dosages now that are possible in children are as follows. Let me just see whether I have those dosages. I think I have a table. It would be prudent for me to talk on them when I really come to that. So whichever nerve block is possible in an adult is possible in children. And ultrasound guidance alone is feasible, absolutely doable when it comes to the continuous catheters. I would take lumbar plexus as an exception. However, with the QL view, lumbar plexus is very clearly seen. Let's come to drugs and dosages. Bupivacaine has a disadvantage because the clearance decreases in proportion to the time of infusion. And for ropivacaine, if we have a clear edge, that has to be the drug, if at all. It's not that bupivacaine is contraindicated, but then decrease the infusion at least on the next day. Here in ropivacaine, we can actually keep the infusion and decrease it as per the demand of the patient. So there is that is the advantage. So for continuous infusion, of course, ropivacaine is a better choice. Infusion dosages are revised now. I'm going to share them with you. Previously, we always felt that ropivacaine in a dose of 0.2 milligram per kilogram per hour was meant for neonates till 1 year, and 0.4 milligram per kilogram per hour was meant for 1 year and above. Now, what we believe is 0.3 milligram per kilogram per hour is good enough for very small children, such as neonates till 3 months. 3 months to 1 year can be anywhere between 0.3 to 0.4, and above is 0.4 milligram per kilogram per hour. This is the revised dosages now, currently. So the dose for continuous infusion of bupivacaine is almost the same, but we are not changing it as per what I just said for ropivacaine. So you can just do a quick mental math if you want. So this is one classic example that I have given you for a child who is about 1 year and 10 kilograms. So the total dose of 0.125% bupivacaine comes to 3 ml per kilogram per hour. When you do, if you do pediatrics day in and out with a little more frequency, this doesn't seem to be that complex. It's pretty easy. We could add clonidine. Having said that, not that I have added clonidine in infusions. I've definitely given clonidine in this particular dose for a 3 microgram or 2 microgram per kilogram in the single shots. This can be another example where a continuous catheter infusion is desperately needed, and there is no way we could do that. But then I thought of coming from the lumbar area, change the bevel to the sciatic one. The sacral direction, change the bevel to the sacral direction and let the catheter be threaded towards the sacral direction from the lumbar, so that we do cover the dermatomes and the myotomes, and in fact the osteotomes here. So this is how the catheter was put in. I've put a lead here to show you the journey. Just wanted to be sure that it was here. So from the lumbar, we were actually there, and then we got the sacral areas as well. Something that is totally missed by us, not totally missed, but maybe let me put it in a different manner. Something that we need to be very aware of is the transition. For the first 48 hours, if we have given them a nice period of pain-freeness, which need not necessarily so. Those who have kept catheters know that they need adjustments. They sometimes need boluses. They sometimes even need a rescue of, say, perfalgan or paracetamol, or they do need Dynapars. So go for multimodality, but the pain scores are very rewarding. take-home messages: just because we have put in a catheter does not mean that we don't have to look back at it. We need to look back at it. We need to monitor them continuously. We need to be in communication with the staff on the floors and the surgical team and the parents as well. So what we can do to prevent rebound pain after the infusion is discontinued is something that is very pivotal. Oral analgesics should be given even before that. And as the pain score naturally is going to get better after 48 hours or even 72 hours, depending upon the intensity of the surgery. So after that, if for the first day, if we have given a paracetamol, maybe after 48 hours, it's a good idea to give an NSAID. If we have given both, then maybe we can increase the dose of paracetamol. So for the first 2 days, don't give paracetamol QID, give three times a day and give one Dynapar and see if you're getting beautiful pain scores, do nothing and have some reserve in your hand to escalate it. Are you getting my point, aren't you? So keep some rescue with you at that time. And that could be your NSAIDs and paracetamol. So here is a total, not that opioid is a very big issue in our country, but here is a recipe for a total pain, opioid-free pain relief for a couple of days. Now, we could either share this with the mother or the parent or the primary caretaker, this kind of a pain score. But these days, actually, it just doesn't matter much because we are in continuous contact on WhatsApp. The sisters are in continuous contact on WhatsApp. And these were the days when we did not have great teams building up. So it was the parent and us, rather me, and we used to have calls. So now we go and ask them. The pain relief team actually goes and asks. And a simple look at the child, or the child can verbalize, but we always score pains as per the age of the child. So peripheral nerve catheters are typically advanced to a sufficient distance into a perineural sheath, increasing the risk of knotting and kinking. Let's give a thought to this. This can happen. Theoretical possibility. Not that I have seen any, but yes, it has become at times a little difficult to pull up a tunneled catheter for sure. Because tunneling has an entry point and an exit point, if you know what tunneling is all about. But if we have excuse me, but if we do have a catheter which can't be pulled out, however, has gone easily, it would be nice to keep the child in the same position through which the catheter was put in. So that is one practical tip. Intervening radiologically with passage of a guide wire has been reported in literature, or surgical removal. I hope it doesn't escalate to that, but that is what can be done. These are all theoretical possibilities. However, we haven't seen any. That does not mean that it may not, it never happens. Always know that. Remember, just because there is a fear of compartment syndrome, that does not mean that children should be left in a torture chamber with pain. Simply for the fear that pain relief is going to give a compartment syndrome. However, that does not give us any right to give a surgeon a dead extremity with a peripheral nerve block, and that to a continuous one. Then we haven't done our jobs well. So thank you so much for listening. And I would absolutely love to take questions.
Thank you, madam. It was a wonderful presentation. I joined little late, so I'm not aware whether spinal is discussed or not. Anyway,
Good equipments now. At the same time, spinal dosages are very clear, very clear. It has to be given, of course, below where the conus medullaris has ended. So it is typically L3 and lower down. So safer that way. And in a very small, say maybe preterm baby, ideal indication would be a hernia or an ARM, a sitting little one held, a warm operation theater, all is a prerequisite, and then a spinal can be given. The ligamentum flavum give is very subtle, very, very subtle. However, it can be done. Good point, no blood pressure drop. A little bit of bradycardia may be seen, but can always be balanced by glycopyrrolate. The problem with spinal is it does not give any post-operative pain relief. Second problem with spinal is it can overshoot. The surgical time can overshoot a spinal block in a baby. For older children, we can give spinal. I don't know why would I buy a headache of postural puncture headache when I can get the same thing out of a dense, well-placed epidural is my question to myself. So we do not touch spinal much unless it is so indicated. And whatever can be extracted out of spinal can be extracted from an epidural for a longer time, is what my take on it is. If
Ma'am, any
yeah,
experience about, regarding continuous spinal?
no, none. No, none. There are no catheters for children for continuous spinals as such. We could borrow those ones in grown-ups, but I haven't done it yet. Maybe I should do one and let you know.
Mhm. And people have started using segmental spinal even in pediatric patients. So your take on that, ma'am?
It's a good take. I won't deny the existence of it. But as I told you, intraoperative analgesia is not my goal. I'm going to stand there. I'm going to give what I wish. What about the post-op? That is what my question to myself would be. I would be more worried about that because everybody would be petrified to give any good dose of fentanyl or any good dose of anything for that matter for a child on the floor. So I wouldn't go for that. I would rather give a segmental epidural, that to a continuous one.
Yeah, ma'am. Agreed, ma'am. Thank you, ma'am. I think there are few questions. Sangamitra, you can take that.
Yes, sir. Ma'am, there are some questions in the chat. So, one second, ma'am. What is the total dose of bupivacaine and ropivacaine in 24 hours that can be given in infusion, including demand bolus? Am I audible, ma'am?
Ma'am, I think you are muted. Vrushali, ma'am.
No, ma'am is not mute, sir.
But we cannot hear, ma'am.
Yeah.
She is speaking something, but we can't.
Yeah.
Now can you hear me?
Yes,
Yes,
ma'am.
ma'am. Yes, ma'am.
Yes, yeah. I heard the question.
Okay.
A smart one. Let's follow the calculations. So the calculations are, suppose above 1 year, say 10 kilogram again, and 10 kilogram, the dose is 0.4 milligram per kilogram per hour. Is it? Now we came to the dose of 3 ml per hour with that calculation of 0.125% bupivacaine because that needs to be diluted. So this is your 24 hours dose. Can't, because, I mean, 3 ml per kilogram per hour is something that you will go on for 24 hours. So that's your cumulative dose. When it comes to boluses, I would bolus a bupivacaine continuous infusion only if, only and only if the child does complain of pain. Otherwise, it's not required. If at all it is required, a bolus dose or a continuous infusion for bupivacaine is not yet properly described in pediatrics. However, we could give 1/4. That is, if 0.5 ml per kilogram of 0.125% would have been a good volume to give here. Now that the epidural or whatever perineural space is flooded by that, I would reduce it to even half, that is 1/4. So 0.25 ml per kilogram would be a bolus dose, and the pharmacokinetics of bupivacaine, let's take it nothing more than 6 hourly. There is one article that I can tell you to refer to is, we have described this in 400 cerebral palsy children. So please go to that article. I request you to type my name, type cerebral palsy and type Canadian Journal of Anesthesia. You will go into the details of how this was handled.
Thank you, ma'am. Ma'am, there's
You're
one
welcome.
question by
Ma'am,
Dr.
Sangamitra, before you move to next question, ma'am, is there any difference between incidence of LAST in neonates and adult patient? Because I've faced LAST once in my career, that was in neonate. Patient was posted for TOF repair. Patient was neonate, and at the end of surgery, we were used to do local infiltration in the wound at that time. It was I mean it was before 22 years, and we patient at cardiac arrest. Luckily, patient survived after CPR of 30 minutes, but that was the only incidence of LAST in my career. So, is there any difference between incidence of LAST in pediatric, I mean neonates and adult patient with bupivacaine?
Point. Uh, Theoretically, the incidence has to be higher because the free fraction of the drug is more because the free fraction is more because of the protein deficiency, alpha
Yes,
protein deficiency,
yes, ma'am.
or the lesser amount. So yes, but hence the milligram per kilogram dosages have to be adhered to very strictly. Hence, the safest local anesthetic is picked up. Having said this, we haven't seen a frank convulsion or we haven't seen frank LAST yet. Yeah. Maybe it was a liberal infiltration that caused a rapid uptake. I can share this also with you. Long time back in my practice, I in fact had, please don't go home with some false sense of security. But by mistake, one of our floor nurses had attached ropivacaine to IV, some 4 ml per kilogram per hour. And the next day, when we went to check, we saw that, and to our horror. So such incidences have happened. Luckily, nothing much happened. I mean, we did not go towards LAST as such. Maybe because it was ropivacaine, I'm not too sure. So, in fact, I have seen LAST in the operation theaters, in the other theater where a geriatric patient was given a block. So I've gone there and helped in managing that LAST, but not as yet, not seen here. And at the same time, you know what can happen is, after we give a caudal epidural in a neonate, in a neonate, and then we changed over. And suppose if it is in concomitant with general anesthesia, we don't give muscle relaxant, so we will see convulsions. But sometimes apnea could be a sign of LAST. I'm not too sure. Because we get apnea. Now, whether the apnea is because the calculated epidural dose has gone into spinal, or because it's some kind of a cessation of spontaneous respiration due to LAST. So we are not too sure, but they come around by usual means, and they don't really require intralipid. But I've not seen any dysarrhythmias, luckily, till now. I think I've just been lucky.
Thank you, ma'am. Sangamitra, you can go ahead.
Yes, sir. Ma'am, there's a question from Dr. Gaurang Kothari. Is there any recommendations to stop catheters in small babies to reduce the risk of neuronal toxicity as recommended in central neuraxial catheter?
Perineural catheters recommendations. If there is any neural toxicity is the question, Gaurav.
Yes, ma'am.
Can you elaborate more on this question? We should not put catheters around the nerve because it can damage the nerve. Is this what you're trying to ask me?
Dr. Gaurang, will you please join us?
Ma'am, what I want
Come
to
ahead
know,
and share your thought with me a little more clearly.
so just like in neonates or up to 6 weeks post epidural or caudal catheters are recommended not more than 24 to 30 hours. So is there something like that for perineal?
I haven't thought of it actually. For peripheral nerve blocks, maybe if there is a pre-existing issue such as a Erb's palsy, maybe there I won't do that. Otherwise, a local anesthetic infusion in a particular given dose, I see I see no reason why it would cause a nerve damage unless I'm putting it inside the nerve, unless I'm intranural.
Okay.
Have I understood your question correctly?
Yes,
You're asking? Yeah. No,
yes,
no.
ma'am. Yeah.
The question is no. It won't. It should not. Why would it? Unless there's a wrong additive in it, which can damage the or irritate the nerve.
Okay.
I'm just thinking now.
Ma'am, Dr. Gaurang has one more question that do
Yes,
you tunnel all your catheters? Any experience of using the catheter fixation device available with B Brown sets?
yeah, I'm aware of the B Brown sets devices. I tunnel them though, because a good tunneling keeps them intact far more than any other fixation I've ever met with. So, especially the infraclavicular, the sciatic, the fascia iliaca compartment, all those catheters can be tunneled. Caudal epidurals we use to tunnel, but here now we've devised a technique where we suppose if this is the exit point, we put the gauze piece here and pull it over the gauze piece like that and keep the entire area under a tegaderm and then put a dynaplast on it. Not very mercilessly though, but that has kept, because our neonatologists got a little worried with the tunneling technique.
I just have an add-on question to this. How does the counseling of parents pre-op or post-op with this, infusion pump with the baby? They are small, they move around so much. How does your counseling goes on? And how many times you have found the parents receptive and difficult for the same?
Yes. I was waiting for this question. Thank you for asking. Your pre-op counseling is something that actually makes your procedures very simple and for easy for them to understand. Most of them are going to be worried about their child's pain. Having said that, we explain general anesthesia and then we explain the regional anesthesia. If it is epidural, we get different sets of questions. If the mother has gotten spinal, she's going to be mighty scared of me touching the child's spine. But then we have to allay her anxieties and tell her that it is one step, before.
Yes, ma'am.
I mean, it's not right inside the spinal spine. It is one step before. That, in fact, it helps her a lot.
Yes, ma'am.
If it is caudal epidural, we have to tell her that where the spine has totally ended, only there we will keep it. That helps them understand it a lot. We typically use language such as a numbing medicine is going to be put around the nerve that supplies the area of operation. And they themselves are so worried about both the lower limbs or one upper limb for 4 hours. The child is going to go under operation and will it be really painful, or will the child suffer so much? So we milk that situation between you and us, and between you and me. We say that yes, it will be painful, but at the same time, we are going to do this particular thing.
Yes.
So we are going to just say that, okay, this is the nerve. We typically give an example. I typically like to give an example of dental surgery because adults understand it very easily. So how the dentist numbs only a tooth. So we are going to reduce the pain only in your child's hand. And for that to continue for good 2 days, we will put a small little tube which is maybe of a hair
Hair like
thickness.
thin. Yeah.
Yeah, and that will give continuous numbing medicine there. This is what we say. And then we also say that you will see a pump with it, which will measure it very precisely, and you'll have to take care of the pump.
Yeah.
So that's how their control comes in, their involvement comes in. Then they ask, oh, is it really very common? Then you jump at it and say, yes, it is very common because this is the best way we can relieve your child's pain. So I think parents come in a different manner to us. It may be difficult for an adult to make them understand about a peripheral nerve catheter, but for a parent to make them understand a peripheral nerve catheter is not very big. So you have to cut the ice with your surgeon first. Show him one or two good cases. Don't give him a dead extremity. He'll be happy.
Yes, ma'am. Thank you, ma'am. One more question from Gaurang.
And take responsibility. Tell the
Yes,
surgeon
yes.
also that we are taking responsibility of it. Something happens, we are more answerable than you.
Right, ma'am. Thank you, ma'am. There's one more question from Dr. Gaurang. If the plan is for spinal and caudal, which one would you give first?
Oh, you want to give both. That also is a good thought because the problem with spinal is it will wear off, caudal will linger, caudal will give post-op. Give spinal first and then go to give caudal. I think. After giving spinal. Because I assume you're quick in giving your caudals. Because your caudal can be densened if you don't get your spinal. By lignocaine, by clonidine. And don't give your spinal with hyperbaric solutions in that case.
Yes, ma'am. One more question from Dr. Veena. Can you repeat the dose of epidural volume and concentration of drug which you will give when you prefer epidural over spinal?
I would repeat in the sense after the surgery, give one more epidural or through the catheter.
I think Dr. Veena, can you join us? Can you?
Veena, can you come clear with the question?
Uh, Good afternoon, ma'am. Good evening, ma'am.
Good evening.
Ma'am, I just wanted to know, initially you told now that instead of spinal, you will prefer an epidural for any procedure when Hetal are asked. So at that time, in the starting of the procedure, what dose and what concentration, like what volume and concentration you will give for a case instead of spinal when you're giving, ma'am? Thank you, ma'am.
Let's go back to the good old example of 10 kilogram 1 year. It is very easy to understand. Suppose this child is undergoing an exploratory laparotomy with, say, just above the umbilical incision. Then I would definitely go to the lower thoracic and give a volume, if it is single shot, give a volume of 0.5 ml per kilogram of 0.25% bupivacaine, say 0.5 ml per kg, and I would add 5 milligram per kilogram of lignocaine 2% with adrenaline. So this will give me a very dense epidural and will really cover a lot of segments. So the dermatomes and the myotomes have definitely gotten covered with this. Does it answer your question? And if I have passed in a catheter, I would still give a dose of 0.5 ml per kilogram at that point. So 5 ml I'll definitely give.
Thank you, ma'am.
Ma'am, one question from Dr. Kavyashri. When you will be choosing caudal catheter versus epidural catheter in pediatric patient?
Kavya, is it? Her name is?
Kavyashri, ma'am.
Kavya
Huh.
Shri, you have asked a question.
Yes, ma'am. Huh.
You have asked a question which shows me that you've thought so much on it. And I'm very
No,
glad you have.
ma'am. Actually, the thing is, like, in what cases you'll prefer the cord, like, both are epidural space only. And if you're choosing a caudal catheter placement, and in what age group and what is the length you fix it, that is the I have doubt, ma'am, regarding that.
That's a fantastic question. You know, children, when they're born, the spine is straight. So neonates, no doubt, from caudal go till thoracic. But don't always think that the catheters would reach. They may not. Still, there is a good chance in this age group to have your caudal portal to be used to thread catheters right till the thoracic point. So we absolutely say yes to neonates. Till 3 months, definitely yes. Go ahead and do that. Then the child starts lifting the neck. Some curve starts setting in. Thoracic, and then the child walks. The lordosis also starts in. Still, there is some chance to get the sacral and the lower lumbar through a caudal catheter till 1 year. Don't expect lower thoracic also. But once the child starts walking, don't even think that it would go anywhere beyond the most lumbar plexus. You really got a lot if you've done that. I mean, if you get it by somehow say hydrodissect, I mean, by putting in saline or, increasing the volume, distending the space, still doesn't happen that easily. So above 1 year onwards, we must be thinking of going to site specificity. So if it is abdomen, lower thoracic. If it is thoracic, go to that particular segment itself. If it is hip surgery, go to lumbar. I mean, go to the lumbar because there is where your lumbar plexus is. So if it is foot, maybe then you might think of putting a caudal catheter.
Yes, ma'am. Thank you.
Ma'am, one
Kavish.
question from Dr. Deepika. What is the maximum duration a catheter can be kept in place in pediatric patient?
Well, usually it is 48 hours because pain intensity decreases in 48 hours. In neonates and infants, it is definitely 48 hours because after that the accumulation begins. However, in grown-up children's case, school going, it can really go long for as long as even 8 to 15 days. We have sent not many, but I have sent one child with catheter home, a sciatic nerve block, and I'm not sure if Srinitya won't be here, right? Srinitya was our student at that time. So she would go home and look after the infusions. So that was kept for around 20 days. Yes, they can be kept, but then there are different protocols to follow, the sterility, the infection, those questions will come in. In a routine practice, 48 to 72 hours is a very safe bet. A well-monitored catheter. In very small kids, what happens is there is a lot of back leak from the epidural catheters or even perineural catheters. I'm sure perineural catheter back leak is an issue in adults as well. So in pediatric, that does happen. In epidural, people start, the staff almost would feel that these catheters are leaking. We need to tell them that this is the case and we need to change the dressings carefully if at all it soaks to that extent. So these are all the extension of our catheters issues that come out, and we need to be really educating them on it so that it can be taken care of, and we need to take responsibility.
One question from Dr. Anju. Ma'am, are you practicing thoracic catheters in infants? If yes, for what indications?
There was a time, or there are a few surgeons who still do it, they thoracotomies. Thoracotomies was one rampant indication where I used to keep absolutely site-specific catheters in the thoracic level. Why not paravertebral? You know what happens with paravertebral? It's a great space to go to, but it's very shallow. That space is very not too far from the skin and the lateral position and the patient and the surgeon's retracting. So the paravertebral catheter might come in their way of their stickings or their work or might get avulsed. So, however, a thoracic epidural catheter can really be fixed away from their incisions and they obviously the trajectory from the skin to the destination is longer. Yes, it is a done thing, but it has to be taken as an advanced technique and it should be done by those who practice pediatric regional anesthesia very, very often and are very well conversant with the fields and the gives of that population anatomy.
Right, ma'am. One more question from Dr. Meghna. Any dose modification in neuromuscular diseases babies?
Meghana, another wonderful question. The commonest neuromuscular disease that we come across here in our practice is cerebral palsy. You would be surprised to know that in fact, we need a bigger dose. We need denser blocks here. Because there is a situation wherein, because there are two types of them, aren't they? One is hypotonic, another is spastic. Would the hypotonic come to us very rarely? The spastic ones come to us because they need muscle tension corrections. They need the tendon releases. They need the osteotomy so that finally finally the ergonomics of the MSK improves and comes in alignment uh, with uh, with general movement of the body as such. These are the children who need a tad denser blocks, in fact, than adults. Than normal children. Here is the explanation for it. A little bit of pain even can trigger spasticity, can trigger a spasm, muscle spasm, and a muscle spasm then triggers more pain. So there's a vicious cycle. So to keep that cycle cut, vicious cycle cut, we really need to give solid blocks.
Yes, ma'am. One more question from Meghna. What would be the length of catheter kept in epidural space for site-specific thoracic epidural?
In what age group?
Dr. Meghna, can you clear?
Ma'am, in like thoracotomies wherein we are expecting cases, so maybe 1 to 4 years of age.
Okay, you know the easiest way to answer your question is you are going to get inside with the epidural needle, right? So you know the length of your epidural needle. Say maybe
Yes,
8
ma'am.
centimeters, right? It has a
Huh,
stillet
huh.
along. Huh? So
Yes,
now you do
yes.
one thing. Once you have taken the epidural space, you've gotten the ligamentum flavum give, and you're very sure. What you do is with that stillet, measure from the entry point in how much centimeter is your point where you want the tip to be. Or take a
Okay.
measuring tape and measure it. Simply measure it actually. Okay. And put that much.
Yes, ma'am.
But for that, suppose if it is 5 centimeters, add those 2 centimeters or 3 centimeters. In a child that you have described, it's going to be 1.5 to 2 centimeters, nothing more than that. So 5 plus 2, so 7 should be at the skin. You understand me? So from skin
Yes,
to
ma'am. Yes,
epidural,
ma'am.
from epidural to the length that you are expecting that catheter to travel. Give more, but don't give less. Because if you think it is more, you can always withdraw. If you put less, then you can't do anything much about it.
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am.
One question from Kavashi. Most common complication which you have noticed in these babies in which you have used catheters, ma'am, and peripheral nerve blocks?
Failure. Failure in spite of a well-placed catheter. That is the complication I have faced. And the reasons
Um,
are as follows.
okay. Ma'am, anywhere like you had a catheter displacement or catheter migration which has led to the complication, ma'am? Because the childs will be like mobile and they'll not stay still. That is.
Actually, I was coming to displacements. They have gotten
Hmm.
displaced. Hence failure, right? They're failures.
Yes. Yes.
Yeah. Or you have kept a good catheter, but nobody picked up that the Baxter pump, the elastomeric pump was not working. Nobody picked it up because an infusion pump gives some alarm. So if that kinks or if that gets disconnected, nobody understands that this has happened. So that's another failure, isn't it? Your catheter not giving analgesia is your failure. So now that it may not be your technical failure from your technical or motor skill point of view, but it is a failure. For a patient, it is a failure, isn't it so? So all these are
Hmm.
failures. So not addressing an inadequate dosage, not addressing migrations, because once they migrate, you just have to remove it. Migration as in disconnection. It doesn't migrate from one place to another. It doesn't happen that way. Because in orthopedics, usually they don't move the limb, which is painful much. And then secondly, they're plastered. Remember that. So the plaster hinders their movements. So even if you keep them pain-free, they are not going to move. They are going to have a slab or they're going to have a plaster on it. So that itself is going to keep them reasonably immobile for the catheter not to come out. You understand me? Yeah. So
Yes, ma'am.
yeah. So this is what I have noted. Hence, uh, there is a problem, then you define, then you devise a strategy. Then what do you tell? You tell the parents, because they are the caregivers. They are the ones who are going to sit beside the kid most of the time. Then the sisters are going to come and go, right? So you should tell them that if your child keep an eye, you should tell 2-3 things. One is keep a watch on, not every second or every minute, but on and off, keep a watch on the elastomeric pump. Layman's language, that pump is going to look pregnant, isn't it? Once it's that balloon inside the bottle is going to look pregnant. That should very slowly become less. And if it is, then it is giving the numbing medicine as much as it should. But if it is reducing and it is leaking somewhere on the bed, please tell the sister. You understand? So we've addressed whether the key is properly set on 5 or 3, whatever, and that the infusion indeed is going on, or it's disconnected. It will get wet. Another failure of mine is our miscommunication between, that I have seen, is a miscommunication between the surgical residents and the anesthesia team. We know that on the elastomeric pump, if it is 5, 7, and 3, in between, if the key is rotated and pot in between, there is no flow. Okay, but they feel that from say 3 to 5, if they get the arrow in between them, probably they're giving 4, and actually it's 0 at that time. So those things have happened with us, and then we had to like share with them that don't do that. And let's consult before touching the epidural dosage or perineural dosage or anything for that matter. So these are logistic. I call them logistic failures. And failures are failure for a patient. Failures are failures. They may be logistic for you. I might be giving a most beautiful ultrasound guided block with a perineural catheter, but that these logistic failures don't give pain relief. It's a failure. It's a complication. The
Thank
biggest
you, ma'am.
complication.
Ma'am, one
Yes,
question
ma'am.
from Veena is how do you explain the risk and complication like last, etc., to parents during consent?
All right. We answer after describing the procedure. You know, you're talking to me, aren't you, right now? By now, have you guessed how eager am I to answer your questions? How comfortable I can be talking to you? Do I look in a hurry, or am I judging questions? It's absolutely not that way, isn't it? Have you sensed that by the way I'm just talking to you? So when you're talking to a parent, you're going to sense how much anxious are they, how much is enough to them, how much more should I tell them. So if a parent is like inquisitive, has read a lot in Google, and is going to ask you about lust, then tell them all about it. And tell them that the antidote is lying in our refrigerator. However, here is a parent who just wants to know whether the child is going to be fine, and says that, okay, I really leave it to you to do what is good. Then you tell them in the most easiest and simple manner what you're going to do. And if they are not going to go towards complications, you don't bring up complications unnecessarily, because that's a way to tell them, that's a way to communicate with them. Don't disturb a still lake. As at the same time, don't say that nothing can go wrong. This is what we usually do. It should be your way of talking. And if they say, इसका कुछ मुश्किल तो नहीं है ना, इससे कुछ कॉम्प्लिकेशंस तो नहीं होगा ना, then the answer should be, हमने देखे तो नहीं है, if you have not seen. Yeah, they are not known to give a lot of complications. If you enumerate, infection हो सकता है, last हो सकता है, जान जा सकता है, cardiac arrest हो सकता है. All that has to be on the consent form. You don't have to keep on explaining that. He probably forget about the block. He probably may not get operated.
Right, ma'am.
He probably would want to go home.
Absolutely.
I mean, these are my opinions, which have hold sway in my practice. These are my experiential truths. It may not be everybody's, but we have a very detailed consent form on which everything is written: GA complications, RA complications, till last.
One more question from Dr. Meghna. How often can peripheral nerve blocks or central neuraxial block be given in babies less than 1 year if the baby is coming for repeated surgeries like urological procedures or ARM correction?
They won't come to you once a week. Unlike a Ponte fracture, a pop plaster, they come to you every week. So I don't see much worry in giving them repeatedly, say once in a month, even in 15 days. But your question is astute. Nothing is described ever in literature. How often can you enter a caudal space of a neonate or an infant? I mean, I gave you for that question. However, this is what the practical insight is. The frontline insight is PU alpha curation. The child is going to come once. Then in the same sitting, they'll do a circumcision. Later on, maybe a valve which is not well fulgurated, maybe after 15 days, or maybe after a month, or some injection at that site. Again, they might come back. Hypospadias, they might keep coming back for a fistula after healing totally, or 2 stages, but then they wait for the first stage to heal and then they come. So it's not that rampant. It's not that frequent.
Okay, ma'am. Thank you so much, ma'am.
Wonderful. Thank you. Wonderful thoughts, Lo. You're thinking.
One last question from Dr. Shetra, ma'am. Follow-up question: when encountered with failure, how do we manage the pain? With IV oral analgesics or repeat the PNB catheter, especially in a painful procedure?
This is a question I've asked myself 1,000 times. Sometimes, it's so, how should I say? Sometimes it is so tempting just to take the probe there and put a local when the child is writhing in front of you, right? Because it happens, especially in orthosurgeries, the Elisa Rouse and osteotomies, they're so painful. So, especially if it's a femoral osteotomy or a popliteal one, 5 ml there and it's going to relieve them. So, however, it's a child is a child, not going to let you do a block on bedside. What we go ahead with is then fentanyl patches. 25 micrograms is per kilo per hour. 25 micrograms per hour release is the smallest patch that we have. So we use that patch. We use paracetamol, but we don't go QID. We go three times a day, and then we go Dynapar. That is say once in the whole day, and we keep some room for escalation. And at the end, we could also go to Ultracet, which is paracetamol and tramadol combination. The tablet is 30 milligrams, and we give an arbitrary dose of 1 milligram per kilogram HS. Okay, so this is how it works. Have I ever taken the child again in the OR to repeat a block? No, no, because the child was on the floors and was crying in pain. I might have wished once or twice, but I haven't done it.
Okay, thank you, ma'am.
So I am floored by the questions. Let me tell you that. I'm glad you all are thinking so much.
Thank you, ma'am.
And I'm really happy to see that they had so many questions related to regional, ma'am. And I guess pages will be a big guidance for them to, to learn more and more about pediatric anesthesia. And I hope to see most of the fellows there. Because if they have so many questions and doubts in regional, to come at the platform for pediatric anesthesia will be a very good opportunity for them to learn from the masters.
That would be an amazing thing because we can spend 2 good days with each other. And it's not just regional, it's overall pediatrics. So lots can be learned and lots can be said, because the best thing about Pages, that is Pediatric Anesthesia Global Education and Synergy, by which is happening in Mumbai on 7th and 8th of June, is we've kept a good delegate discussion dialogue for a good 30 minutes after each theme. And we have a live relay of pediatric procedures from the operation theater, which is, I guess, is the rarest of all rare events. And I think you should jump in. And it is endorsed by the World Federation as well as the Asian Society of Pediatric Anesthesia. So if you present anything, you get an endorsed participation certificate also. And you get exposed to quite a bit of foreign faculties too.
And we are at the end of question. There are lots of thank you, ma'am. Excellent session from the kids. They have all loved today's session, ma'am. And thank you so much, ma'am, for sharing your thoughts and experiences with us, especially in the era of pediatric anesthesia, which we all know we are always scared, whether it is pediatric anesthesia or pediatric regional anesthesia. Not only the kids, even I had so many doubts which got cleared today, ma'am. So thank you so much, ma'am.
I understand. Thank you.
Thank you, ma'am. Good night.
Thank you. Thank you, Hetal, and thank you.